Welcome, everyone, to our Medscape highlights of 2024. We're so excited to have Professor Alfonso Fasano joining us today. He's a professor of neurology at the University of Toronto. My name is Indu Subramanian. I'm at UCLA, and I'm excited to hear about Dr. Fasano's highlights. He's always a fun person to learn from. He's an amazing educator and researcher, and so we are excited to have him here today. Alfonso, perhaps we can start with the new definition of Parkinson's disease and synucleinopathies and RT-QuIC. Perhaps you can tell us a little bit about, what your thoughts are, what the highlights were this year.
Sure. First of all, thank you, Indu, for the nice introduction and for inviting me. Back to your question, even though this might sound like research-based, and it is research-based for now, I think it's important that our listener will understand that the definition of Parkinson's might change soon. Because we've been looking at new ways to biologically characterize the disease. We've been knowing for years the genetic contribution of Parkinson's. We have a number of biomarkers, think about that scan, but also alpha-synuclein deposition in the skin. But now with the recent introduction of a seeding assay, you mentioned RT-QuIC, clearly our understanding and diagnostic accuracy of synucleinopathy has improved so much that the field has now come to the conclusion that we really need to implement this new framework into what we call Parkinson's disease. So simply put, we're talking about seeding assays. Seeding assay actually is part of routine neurological practice for diagnosing prion diseases. It is a sort of a PCR for protein. It's something that amplifies pathological protein, and it's been, as I said, invented for prions. Less than a decade ago, people started to look into whether we can amplify alpha-synuclein, which, as we know, is the main protein accumulated in many conditions that we call synucleinopathy. And Parkinson's disease can be, to some extent, considered a synucleinopathy. So we have achieved incredible accuracy in diagnosing the presence of a synuclein pathology in the brain. We're talking about sensitivity, specificity well beyond 90%, 95% and above. Because of that, two groups of independent researchers have published this year in Lancet Neurology two different papers. And I won't go into details because it's quite complicated, but this is just to say that in these two papers, there are slight differences between the two. For example, one talks about a new definition of a condition that they don't even call Parkinson's disease anymore. They call it neuronal synuclein disease. The other paper instead say, no, we should stick with Parkinson's disease, but we need to stage Parkinson's disease based on these biological findings. So again, no need to go into details, but as you can imagine, this has introduced some debates in the field. Bottom line is that probably soon we'll have so much control over the understanding of whether there is synuclein deposition in the body, even years before the disease starts, they will really be able to classify the disease and identify stages even before the disease actually manifests. It's key for the next step, which is not symptomatically treat Parkinson's disease, but to identify people that are about to develop the disease so that we can implement a treatment that are meant to be protective.
Great breakdown of that very complex area. So tell us a little bit about the highlights of genetics. There's so much going on, honestly, worldwide. It's a very exciting time in genetics.
Genetic has been the revolution of this field. We've been talking, for example, about synuclein, but we know about synuclein because the first gene ever discovered in Parkinson's, there was the gene for synuclein. But right now we have many genes involved in the disease. There are either very strong gene that we call monogenic type of Parkinson's, where if you have a mutation, you have a certain risk to develop, depending on the penetrance, to develop the disease. A classic example would be LAR2, which is a very common autosomal dominant type of Parkinson's disease. We also have genes that are very common in the population, or for sure more common, but they are seen more as risk factor, and probably the most important in this context will be GBA1. So more recently, there have been an interesting publication in publishing in Brain, where this is the Rockstock Parkinson's disease study, ROPAT, which is an observational study enrolling really thousands of people with Parkinson's and control. And this study identified a mutation of one of the genes that we know are related to Parkinson's disease in 15% of the patients. So 15% of our patients in any clinic, we can say have a genetic underpinning. Sometimes it's a multifactorial problem. Sometimes, as I said, a strong genetic contribution. Why are we doing this? Because once again, we'll probably deal in the near future with a precision-based approach to treatment of Parkinson's disease, whereby we will see what genetic condition the patient might have and determine what therapy, what drug to use for that particular patient.
So the next area I think you mentioned was, what are the next steps, right? So we have a sense of now this, we have proteins that we're identifying, we have some genes. We've to date, I think, not been able to find anything that's truly neuroprotective in our armamentarium. But in terms of disease modification, where are we? Can you bring us up to date on what your thoughts are with that?
I can probably mention three papers. The first one is a trial that was ran for over a year. It's a large trial, well conducted, published in New England Journal of Medicine, and it's a trial conducted in Europe using a drug called lixisenatide. So this is part of the so-called glucagon-like peptide-1 receptor agonist. These are drugs for diabetes, and probably the big public knows about exenatide, which was the very first drug shown to change somehow the progression of Parkinson's disease. So this group of physicians and colleagues, mainly from France, they did another randomized control trial using a slightly different drug, but still part of the same family of drugs already approved for diabetes. And they were able to show an effect on the motor scale of the disease, and not just the motor scale. So even after a washout period, people that have been exposed to the drug were doing better than people that were receiving placebo. So this is kind of aligned with what we've seen in the past with exenatide. Another study, though, and this is using a more specific drug called LNLY01. This is belonging to the same group of drugs with an anti-diabetic effect because they are GLP-1 agonist. But this in particular is a drug that has also the potential to have an effect on macroglia. In Parkinson's, we know that especially early on in the pathophysiology of the disease, there is some inflammatory change going on in the brain, obviously with the role of microglia. So this is a mainly American study published in Lancet Neurology. These colleagues look at this product and they said, okay, this is a perfect situation because it's a drug that it works on the same drug like exenatide, so might do something good to Parkinson's and also has an effect on microglia. But unfortunately, this study was negative. Overall, emphasizing the fact that at the moment, even though all of this is very promising, we need to learn more. Personally, from a clinical standpoint, when I have a patient with Parkinson's and diabetes, I ask the diabetologist or the family doctor to consider to use one of these drugs. I will not put a Parkinson's without diabetes on one of these drugs, but if they happen to have diabetes, then you try to kill two birds with one stone. But the evidence, which was very encouraging before, now with this latest study, seems to be a little shakier. So more to come, but absolutely this is interesting. Another type of approach, which has been quite controversial, this is the post-hoc analysis of the Pasadena trial. Pasadena trial is a trial that used an immunological approach to removing alpha-synuclein aggregation using basically an antibody. The drug was called prasinezumab, and the trial actually was negative. But in a post-hoc analysis published in Nature Medicine, they looked at whether there were predictors of success. And amongst the many that they explored, they found out that people with a more aggressive type of Parkinson's, what we call malignant Parkinson's, they tend to have a slower progression compared to the same type of patients exposed to placebo. So it is complicated. Our dear friend Alberto Spey, as you probably know, is against the hypothesis that just removing synuclein is gonna do any good to our patients. But at this point, at least this post-hoc analysis seems to indicate that maybe we need to do more studies and we need to be better at selecting the right candidate. And in these people, we really need to test again the hypothesis that such approach, anti-synuclein, can be possibly effective. At the moment, it's hard to tell.
Yeah, such a complex area. I think one of the thing a note of caution in the GLP-1 drugs, many of our patients are at risk for weight loss, anyways, and as they lose weight, especially as their disease advances, that can be sort of a harbinger of things to come, like bone breakage and falls and other things. So I think in a frail population, certainly we need to be very mindful of trying medications that could result in weight loss that then have other adverse effects down the road. At the moment, I'm being quite cautious as well in this population of using the GLP drugs, unless of course they have diabetes, as you mentioned. So I know that I love lifestyle modification and exercise, um, and uh, and so I know that you had pulled some papers from this year looking at this. So maybe you could highlight something that you had found in the exercise realm.
When I received your invitation, obviously I was honored, and I said, "What's the best way to give the listener an overview of what's really hot?" And then, as a researcher, I went online and I looked for the most downloaded and most quoted papers. And I was initially only going for original papers. Now, as you know, in the field of exercise, lifestyle modification, diet intervention, unfortunately, journals are not that interested in this. Probably things are changing now, but you happen to see these publications usually not in the classic high impact journal. But thankfully, I managed to find a paper that's being quoted quite often, which is actually a network meta-analysis published by the Cochrane Group. Network meta-analysis is basically a meta-analysis where also you can identify a certain order of effect. So you can say of number of procedures and interventions that have been explored, which one is better. You can actually rank them from the most effective to the least effective. But without, again, going into too many details, this meta-analysis I was talking about looks into the effect of physical exercise for Parkinson's disease. And guess what? They show that physical exercise helps Parkinson's disease. It reduces the motor scores, and not all the interventions, but a discrete amount of those interventions can also improve quality of life, which at the end of the day is the real goal of what we do when we treat our patients. So this is the very first time that I see a Cochrane database systematic review being so specific about exercising for Parkinson's disease. In the past, they have published similar meta-analysis where the answer, the conclusion was always, well, we need more studies. The evidence is poor. Thankfully, we are not in that situation anymore. We have good evidence that many approaches, including dance therapy, for example, help from the different perspective of the disease, and they are quite safe. The analysis also looked into the adverse events and basically found very minimal risks with such approach. So absolutely, this is something that needs to be emphasized over and over, more than drugs. Probably you agree with me, but unfortunately, drugs are the kind of studies that you more easily find published and quoted, and often may make it to the news more than just saying, "Hey, aerobic exercise is good." Actually, I don't remember who said that, but if aerobic exercise was a pill, was going to be the most prescribed drug ever.
Yeah. Yep. No, absolutely. I think exercise is medicine, and we both believe that. And it's exciting that dance and these other things that can be, sort of more culturally, sort of contextual for our patients can also be prescribed in some way. So I think that's very exciting. So we're moving on now to the advanced therapies. I know this is an area that's near and dear to your heart. Maybe we could talk, briefly about infusions and what's been new this year and hot, and then also perhaps, we'll get a quick update on DBS and focus ultrasound.
Let's talk about subcutaneous infusion. Parkinson's disease is being treated for years, basically for decades and decades, with subcutaneous apomorphine in Europe, particularly starting in the UK, but also in many other countries in Europe. So the idea that a neurologist could treat Parkinson's disease infusing a dopaminergic agent like apomorphine under the skin has been, around for decades, as I said. But apomorphine is a dopamine agonist. And obviously, we, especially in North America, we prefer to focus our treatment on levodopa. And which raises the question, can we administer with a pump levodopa under the skin? And the answer is yes. In 2024, a paper authored once again by Alberto Spey and our colleagues explored in a double-blind, double-dummy study the role of subcutaneous levodopa infused for 24 hours. This is a product that is not approved yet, and this is developed by Neuroderm and Mitsubishi. And the study was positive. It showed an improvement of the on time about 2 hours, close to 2 hours, and a reduction of the off time close to 2 hours. So very, very promising data, which is matching what we're seeing the year before in another trial with a similar design where the drug in question wasn't levodopa, it was false levodopa. So false levodopa can be infused subcutaneously for 24 hours. False levodopa is more soluble in water, and therefore you can have more levodopa in the end in a single vial. And this was published last year. It was positive, and this led to the FDA approval, which took some time because of the pump, not necessarily because of the drug itself. And now this product is called Vialef and is manufactured by AbbVie, is approved and is commercialized in many countries, including the States. And as you can imagine, because of the continuous infusion of levodopa, as we've seen with the other trial that I mentioned, you have an improvement of the off time and the on time. It doesn't come without problems. If you want, we can discuss that too, but I know that we need to focus on the highlights only.
Let's move on to DBS and focus ultrasound.
Absolutely. So in terms of DBS, really, there's not much I would say that needs to be discussed right now. So DBS has been so successful over the years, and it's been an incremental success. Probably in 2025, we'll have some important results in terms of adaptive stimulation. But sticking to this year, probably when you tell me about deep brain stimulation, there's one paper that I like to mention that is more into actually basic science, but it uses deep brain stimulation to understand how the brain works. This is a paper that was led as a senior author by Andy Orn in Boston, published in Nature Neuroscience. And in this paper, they collected a number of people with deep brain stimulation of the subthalamus. Some of them have Parkinson's, but also other conditions from tic to OCD. And what this paper adds was that looking at the best spot in the subthalamus to help the different conditions that they were dealing with, they could identify different circuits that were tapping in different areas of the cortex, particularly the frontal cortex, which I found fascinating because it's a way to combine what we see on day-to-day basis when we help our patients with the understanding of how the brain works during normal conditions, but more importantly, during pathological conditions. And then lastly, focused ultrasound is just a non-invasive way or minimally invasive way to lesion, to ablate certain parts of the brain. And a group in Madrid, led by Professor Bezo, has been the pioneer in doing subthalamotomies using focused ultrasound. And this year, they have published the long-term outcome of people who had received unilateral and then a subsequent stage contralateral subthalamotomy. So people with bilateral subthalamotomy, basically with Parkinson's, not done at the same time. This is not approved for Parkinson's use, but it's very promising because, as you can imagine, imagine targeting the subthalamus has a very profound effect on the motor symptoms of Parkinson's disease. There are some risks, speech worsening, also dyskinesias, weight gain to some extent, but I think this is very promising, and I'm sure in the years to come we'll see more and more of this treatment. Focused ultrasound also used for many other tremor conditions, and this year there's been an interesting publication by a group in Australia that have looked at the effect of thalamotomy done with focused ultrasound in Parkinson's tremor, dystonic tremor, and essential tremor. And they basically showed that for essential tremor and dystonic tremor, we have good and long-lasting results. For Parkinson's tremor, we see that the effect tends to fade away, which once again emphasizes the need for to look for additional targets. I mentioned subthalamus. Right now, there's a trial going on where the target is the PTT, the pallidothalamic tract. I won't go into details. Maybe next year we'll talk about this trial.
Wow. We covered so much in this short time. Thank you so much, Alfonso, for joining us. I think this has been, sort of a nice tour of all the, sort of interesting and complexity of movement disorders, and specifically, we just talked about Parkinson's. We didn't even get into all the other sort of disorders that we take care of. So I thank you for taking the time to do that, review. I know it was time consuming, but I think it really was led to sort of us getting a sense of like really what the impactful papers were and where we are in our field today. So I thank you so much. Thank you also to the listeners for joining us.
Thank you.